what's your protocol when you get them into? Well, here we go. It's careful questioning and case history taking.
So careful questioning is important, and you know, for all the talk that we've had about sexual dysfunction, subtle anaesthesia, loss of sensation of urine and feces, that unless you ask those questions directly, the patient is very unlikely to volunteer, because they don't understand the connection between bladder, bowel, saddle area sensation, sexual function and back pain.
And more importantly, they'll be embarrassed to talk about them.
Likely. So they're certainly not going to walk in and go, I've got a bit of back pain, but do you know what? I also can't wee. They're not likely to make that connection to you unless you say, have you noticed any change? So it's important that you are not afraid to ask the questions and use simple language that they understand. Don't say things like, you know, how is micturition for you these days?
Yes.
Not going to be helpful to them. So, you know, and also avoid leading questions which might prompt them to give you the answer that you're thinking you should get.
Yeah.
Nothing wrong with urine, is there? Everything's okay in the old downstairs department. Is, you know, patients will go, oh yes, everything's fine. So, you know, don't ask a leading question one way or the other. Don't invite them to give you the wrong answer or an answer that you want to hear.
Yeah. Just to take you back a stage, Kathy's asked, actually what I think is quite a useful question. She says, can she check, is a disc extrusion the same as a large disc bulge?
Yes.
And it does make you think, doesn't it? There's so many words, different words used to mean the same thing in medical terminology. I remember when you and I were going through training, they differentiated between a herniated and a prolapsed disc, when actually, frankly, it doesn't make any difference.
No, it doesn't.
All that matters is what the disc is doing when it bulges or extrudes.
So it's bulging, extruding, herniating, prolapsing. Sequestrating is a little bit different, because that's a kind of a further development of the disc actually coming away within the spinal canal. But do you think the term prolapse, actually that's an alarming word for a lot of patients? Yes.
Whereas bulge or herniation, they sound a lot friendlier.
I tend to use bulge as a general term. I avoid herniating and prolapsing because, you know, what does it actually mean to a patient who is coming into your office and wanting an explanation of what's going on? We all understand the term bulge, but you know, the other terms don't really mean a great deal to most patients.
What do you say to patients who ask about slipped discs? Do you explain the nature of a disc and how it can't really slip? I kind of bat it straight back by saying it's a term we don't use anymore. It's not particularly helpful and it doesn't accurately describe what happens. We talk more about a bulging disc than a slip disc. Yeah, okay. Right, well, hopefully that's put Kathy's mind at risk about extruded discs anyway.
Yes. So in terms of what we're going to talk now specifically about the bladder function. So what is our role when we're referring specifically to the bladder? So we're going to ask questions like, have you noticed any change in your ability to go for a wee? Be very direct about it. You know, can you feel when your bladder is full? It's a sensation we'll all experience on a day-to-day basis, but might not necessarily think about it until somebody asks us.
Would you preface this with explaining why you're asking the questions?
Yes. So the very first point you make is I'm going to ask you some questions which might sound a little bit odd, but the reason I'm going to ask them is your bladder, your bowel, the area around your saddle and your sexual function is controlled by the nerves that come out of the spinal cord, and they are what are known as the sacral nerves, and if damaged, they can affect the ability for you to control the function of your bladder, your bowel, and the sensation around that area. So the questions I'm going to ask you might seem a little bit odd, but it's important that you answer them because it will help me to work out whether there's something more serious going on.
Yeah.
So, have you noticed changes in your ability to go for a wee? When you stand there or sit there waiting to have a wee, does it just happen as you would expect, or does it take longer than you might expect? Can you feel when your bladder is full? When you have a wee, does it feel normal? Do you have sensation of passing urine? Is the stream normal for you? Is it a dribble? Is it a trickle? Is that, if it is that normal for you? Be aware of other factors that can also impact this. Like for some people, certain medications can affect their ability to pass urine. Prostate problems, UTI problems can all be relevant.
Sure.
But again, we're looking at something that contemporaneously matches up with the onset of their back symptoms and leg symptoms.
Do you have any examples of the medications which do give those sort of symptoms?
That would probably relate more to bowel problems. So codeine, for example, can cause constipation. Some of the naproxens, the non-steroidal anti-inflammatories like naproxen and Voltarol or diclofenac can cause stomach upsets, which can cause diarrhea. So It's also important to recognise that some cough mixtures can cause retention and issues with bladder and bowel function. So always ask patients what medication they're taking, because it does help to build. There's a huge swathe of medications that affect bladder and bowel function. So too many for us to go into, but just to be aware that there may be some issues there.